السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله
ازي
وبركاته.
حضرتك يا دكتور؟ يا رب يكون حضرتك بخير.
الحمد لله رب العالمين، إن شاء الله تكونوا كلكم بخير.
إن شاء الله. شكرا جزيلا يا دكتور، احنا جاهزين نبدأ إن شاء الله.
آه، okay. I know this is a بسم الله الرحمن الرحيم الأول. I know this is a very tough topic, and let me share the screen. Do you see my screen now?
ظهر يا دكتور.
ظهر يا دكتور.
Okay. بسم الله الرحمن الرحيم. This is a tough topic, I know. But the issue is that in all my presentations, I know that the attendees are at different levels of education and experience and training. So what I do is that I prepare the article as if it is only for the highly qualified neonatologist in academia, like a professor of neonatal perinatal medicine. And then every and each one will find his match of information. Like if you are still a junior resident, you don't have to know all these pieces of information. Just the highlighted information is more than enough for you. And those in the middle, like practicing neonatologists or those who have master or doctor degree in neonatology, will have a higher level up to the professor. So don't get frustrated. Don't think that this is very tough for you. But take it easy and get as much as you can of information that fits your status of training, education, and practice. This is number one. Number two, in the last session, I have two corrections. I said angiotensinogen like 2 or 3 times, and I meant angiotensin. So when you review the presentation, be careful about that. Another issue is that I said that preterm babies can concentrate urine as much as the term babies do, which is not correct. It is the other way around. Both term and preterm babies have problem diluting and concentrating urine, but preterm babies compared to term babies cannot concentrate urine more, but they may be able to do more or less similar dilution of urine. Okay, last time we discussed the physiology of fluid and electrolytes and fluid and electrolyte homeostasis, the compartments, the regulatory factors affecting fluid and electrolytes. And we focused on the kidney. We mentioned the role of all other organs. We discussed the hormonal regulation, the autonomic nervous system, capillary permeability, and lymphatics. And we gave a brief presentation of the fetal physiology because it will help you understand the behavior of the preterm babies at different gestational ages. And then today we have to start at the immediate neonatal changes in fluid and electrolytes in the first few days of life up to the end of the neonatal period, because this is a very dynamic process. So we'll go to slide number 77. So the baby is born after a long time in utero, where the baby was totally dependent on the mother for fluid and electrolyte homeostasis. That placenta was taking care of all the problems. And once the baby is delivered, he has to face everything by him or herself, has to deal with the fluid and electrolyte issues. And so there is a transitional period between the immediate delivery time and rest of the neonatal period. And compared to older children and adults, the baby, whether term or preterm, has a low renal blood flow, which starts to increase. And it will present between 8 and 10% of the cardiac output. Also, the net filtration pressure, which is responsible for the filtration of the tissue fluids, will increase. And the ultrafiltration coefficient in the kidney will also start to increase. If we look at the preterm babies, they start losing double weight loss. The term baby will lose some weight loss between 5 and 10%, and the preterm baby will lose between 10 and 20%. And you have to allow that, taking into consideration that these excess extra cellular water compartment is something that makes the newborn baby at the verge of possible dehydration versus overload if you give more fluids. So Why there is immediate adaptation after delivery? Because the baby loses connection to the placenta, which has low pressure compared to the totally independent life after delivery, where the baby has to deal with the vascular pressure, the pulmonary pressure, and all these issues, which will affect the renal blood flow, as we mentioned. Also, the autonomic renal regulation starts to be more mature. The baby usually passes through 3 phases. Phase 1, which is called transition phase, which is the immediately after birth, there is like a few hours of oliguria, then comes this phase, which is called the diuretic phase. And this diuretic phase takes from few hours to up to days, based on if the baby's term, is the baby's preterm, and if preterm, what is the gestational age. And most also, don't forget that there is also increase in sensible water loss from the skin, especially in the preterm baby. So this phase ends when the maximum weight loss happens, which is 5 to 10% in the term, 10 to 20% in the preterm, based on the gestational age. Then comes another phase where the diuresis stops and the renal, the urine output drops relatively, and the insensible water loss drops. And this is a very important phase, because this is the time when you go up on the fluids, when you start giving electrolytes, sodium and potassium, especially in the preterm baby. It takes between 5 to 15 days, and then it's followed by the stable growth phase, which is phase 3, which is the rest of the neonatal period, when the baby starts to gain weight. And it's at this point, the weight gain is not water and electrolytes, it's muscle weight, fat. It's real gain in the solid part of the baby. And normal weight gain is between 10 and 20 grams per kilogram body weight per day. So in the early phase, the baby is liable to volume depletion if you don't compensate it after the diuresis stops and after the insensible water loss decreases. Okay. Number 2, we mentioned this before. The baby has all the hormones required for the regulation of the water and electrolytes, but the response is diminished, especially to aldosterone. And also, the baby is not only, especially the preterm, not liable to volume depletion, also it's liable to fluid overload and edema, meaning that the window between volume depletion and volume overload is very narrow, based on the intake and losses. So you have to be careful about that. And it is better to be on the dry side, on the closer to the volume depletion, rather than to the side of fluid overload in the preterm baby, because volume overload increases the morbidity and mortality, like increasing the risk of patent ductus, increasing the risk and the severity of BPD, and the outcome from those conditions and other conditions. And the early phase, it's more, diuresis is mostly water. It is mostly water. And especially in the preterm baby. So it is not, electrolyte loss is minimal, especially for the potassium. So we said that this is the weight loss, 5 to 10% in the term, 10 to 20% preterm in the first week of life because of the initial phase of diuresis, and also because of the high insensible water loss. And the more immature the baby, the more pronounced the contraction of the extracellular space. The fluid comes mostly from the interstitial fluid to maintaining intracellular compartment and intravascular compartments more or less the same. And there is an important point also. Early, after the diuresis, the newborn is liable to hyponatremia after the diuresis. So you have to start replacing sodium immediately after the diuresis. For potassium, in the preterm babies, in the first 24 to 72 hours, there is hyperkalemia of the newborn baby, of the preterm baby. And it is because of the shift of potassium from the intracellular to the extracellular compartment, in addition to starting feeding the baby, and most of the potassium loss is in the feces. So if you don't start PO because the baby is very preterm or there is some clinical condition, so the fetal loss will be minimal or less than expected. Chlorides follows the sodium. And this is an example of how much is the insensible water loss in the babies, term and preterm, to know that it's a significant amount of water, and it's only water, no electrolytes. If the baby is less than what is less than 1,000 grams, the insensible water loss is 60 to 80 milliliter per kg per day. It's enormous. It's an enormous amount. Between 1,000 and 1,500, 40 to 60. Above 1,500 up to term, it's only 20. And this amount in the first day, first few hours of life, and it diminishes as with age, with advancement in the postnatal age. It will diminish. So, based on the insensible fluid losses, there is a table that will show you what are the maintenance fluids required in the first month of life to know how much these babies are in a dynamic state of change in fluids and electrolytes. If the baby birth weight is less than 750 grams, the insensible water loss can be as high as 100. And the total requirements of fluids in the first 1 or 2 days is between 80 and 140 based on the gestational age. And you see that the requirements increase between day 3 and day 7 to compensate for the diuresis and the weight loss that we see in the first week of life. And then after that, the rest of the neonatal period, it's between 120 and 180. So it's stable. It becomes stable, and the maintenance is stable after that. Doesn't go up or down. And the more you go up on the birth weight, the less the insensible water loss, the less the daily requirements of fluids initially and later on. This is a presentation of some of the hemodynamic of the homeostasis changes in fluids and electrolytes in the very low birth weight infants. And it focused on the the pre-diuretic phase, which is phase of oliguria, and then the phase 1, which is the phase of diuresis, and some natriuresis. That's why these babies are liable to go into hyponatremia, as I mentioned. And then after that, he made all the other phases in one under one title, the homeostatic phase.
لو
So
سمحت دكتور ايهاب ممكن نعمل
نعم
سلايد؟
نعم
ممكن نعمل سلايد؟
نعمل ايه؟
ايوه سلايد شو.
ايوه. This is more
تمام.
okay. So the age for the pre-diuretic phase takes hours. And then the diuretic phase takes days, between 2 and 5 days. And then the first between 5 and 7 days is the homeostatic phase, and then it will continue with the growth phase till the end of the neonatal period. Urine output is initially low for few hours, but there is abrupt increase. There is polyuria after 1 or 2 days and stays for like 3 to 5 days based on the gestational age and also based on the intake. But the weight loss should not exceed 5 to 10% in the term, 10 to 20% in the preterm based on the gestational age. Okay? And then he will show you the sodium excretion, minimal in the first few days in this pre-diuretic phase. So that's why we don't start sodium in the IV fluids or in the TPN at this time. And then because of the diuresis and because it's more water than sodium, sodium starts to, sorry, because it is both water and sodium, there is a possibility of hyponatremia because the kidneys will start to secrete more sodium in this phase. That's why we don't introduce sodium in the first 1 or 2 days. We introduce them around the end of the diuretic phase, and then it will become constant later on. Potassium, also in the oliguria time, there is minimal excretion and the abrupt increase in the excretion in the diuretic phase. But remember, potassium is not, only 15% of potassium is excreted in urine and the rest through the GI when you start feeding the baby. That's why potassium does not drop dramatically in the preterm babies compared to sodium. So the preterm baby at some point is liable to have hyponatremia and hyperkalemia. That's why we start sodium earlier than potassium, and don't start potassium unless you have good urine output. Okay? And then these are the rest of the table. After the baby goes into the growth phase, the baby requires sodium. Sodium is a growth factor. So don't allow your preterm baby to go into hyponatremia because this will hinder the weight gain. And the mechanism that helps sodium to help growth is through the sodium hydrogen antiporter. Antiporter is a protein that allows electrolytes to go back and forth, like two electrolytes to exchange back and forth from the cell to the interstitial fluid and the other way round. So this antiporter is responsible for the growth of the different cells, including the muscles and the brain and every organ. Okay, so we talked about hyponatremia and Also, we talked about the inability to concentrate urine, inability to dilute urine for both term and preterm. And this represents the changes that occur immediately after birth, and how the total total weight drops, and because of loss of free water, and then the compartment for free water drops, and the solid the solid the solid part of the body will become relatively increased. And we talked about this and how the compartments change, and how there is shift between the intracellular, interstitial, intravascular compartments before. We mentioned this before. Okay, after we pass through the diuresis, because we know this baby is liable to hyponatremia, especially preterm, so we have to start giving sodium and go up on the sodium. Okay, potassium should not be administered to extremely preterm infants until urine output is established. And because the baby will already have or liable to hyperkalemia. If you give potassium without a good urine output, you are making hyperkalemia worse, and hyperkalemia is something serious. So based on this amount of information, and we refer to this already, what are the daily requirements of fluid and electrolytes? Based on the aforementioned facts, we'll summarize again what are these daily requirements. It depends on the balance. It depends on how mature is the baby, term or preterm, and what is the gestational age, and what is the postnatal age in days, as we mentioned. So we have to give free water, we have to give sodium, we have to give potassium, chloride, bicarb, if needed, in a smart, wise way based on the age, maturity of the baby. Okay? So this table will summarize this. In a term unit, this is the free water or the fluid intake. In the term, first day between 60 to 120 milliliter per kg, and second day will go up a little bit, and when the baby is stable, 140 to 160. The preterm, depending on the gestation, on the weight, it may be more or less similar to the term if more than 1,500. If less than 1,500 grams, the fluid requirements will be more. As we mentioned before. First day may be 80 to 90, and then you go up till a total of 160 and 180 after diuresis. And usually when you start the electrolytes, the sodium, you start between 2 and 3 milliequivalent in the fluids, and potassium 1 to 2, and chloride the same as the sodium. Yeah, this is also another table, another school for fluids and electrolytes. It's more or less the same as we mentioned. Sodium, when we start sodium after the diuresis between 2 and 5, usually go 2 to 3. In the term baby, we go higher because the baby is more liable to hyponatremia after the diuresis. And on the potassium, we give less potassium relatively because of the hyperkalemia till the baby is stable, and then the requirements will be more or less the same. And this is this table for some of the IV fluids that we use in the NICU. And if you give, it shows you how much sodium and how much free water you give in your IV fluids. If you're giving 5% dextrose, you give 0 sodium, 100% water. If you give 0.2 saline, it's 34 milliequivalent, and the water is 75. If you give 0.45 saline, the sodium content is 77 milliequivalent per liter, and free water is 50%. And then the normal saline, all of us know that it has 154 milliequivalent per liter. The fluid requirements could be influenced or modified by other issues, like environmental issues, the temperature, the heating using a radiant warmer, using old phototherapy machines, and if the baby is sick, and what is the sickness? Is the baby disease causing loss of fluids and electrolytes, like like if you are doing compression, decompression of the GI using an NG tube, or if losing fluids from other sources like the CSF. Also, humidification is important, and you should humidify the fluids given to the baby through the respiratory tract. Sorry, that not the fluids, the gases when the baby is on oxygen, whether mechanically ventilated or on other way of oxygen. Oxygen should be humidified to minimize the water loss through the respiratory tract. The loss could be, as I said, from the skin if there is like omphalocele or gastroschisis, and in these conditions, we go up more on the fluid requirements. So how to assess your fluid and electrolyte status? You go clinically, and clinically you do history, and you do physical exam, and then you do labs. And history, maternal history, and immediate fetal history, gestational age. Maternal history is important because giving fluids to the mother will change the fluid and electrolyte respectively in the fetus, in utero. And if the mom has polyhydramnios, oligohydramnios, this is important. Perinatal asphyxia is extremely important because it can affect every and each organ, especially the kidneys, can cause AKI, can cause disturbance in the fluid and electrolyte homeostasis. And other pathologic conditions like using paralytic agents, which we don't use much now, like if the baby is having peritonitis, or if he's having congenital hypertrophic pyloric stenosis. Also, maternal diabetes will affect the baby, as we know. We discussed this when we talked about the infant or diabetic mother. When we do physical exam, we focus on the vital signs, the general condition, signs of dehydration, and signs of electrolyte disturbances. And we are going to discuss these in details. Vital signs like the temperature, the heart rate, and the blood pressure. And if the temperature is high, this could be part of that increases water loss. If the temperature is low, this is a bad sign that the baby is very sick. General condition, does the baby look very sick? Is he apneic? Is he limp? Is he pale, cyanoid? All these conditions affect the water and electrolytes. And then signs of dehydration based on the degree of dehydration, mild, moderate, or severe. We'll have a table for that. And signs of electrolyte disturbances. We'll go through that. What are the signs of hyper and hypokalemia, hypo and hypernatremia, hypo and hyperchloremia, and acidosis, high or low bicarb. So we have to keep the baby as warm as possible within the physiologic range. And we have to take care of the high temperature in the environment because this causes heat loss. Causes water loss in order to drop the heat, the temperature of the baby. So this is important. One of the issues that we should know that usually in older children or intern babies, we know that loss of skin turgor, sunken eyes, sunken anterior fontanelle, dry mucous membranes are signs of dehydration, like severe dehydration. But in the preterm babies, they are not as sensitive indicators as in the term baby. So don't wait for in a preterm baby to have the sunken anterior fontanelle or altered skin turgor or dry mucous membranes. Also, when we talk about vital signs, the first sign to be altered when there is dehydration is the heart rate. There is tachycardia. And don't wait for a baby who is losing fluids, who is dehydrated, who is on his or her way to be shocked, to have a low blood pressure. If you have a baby with low blood pressure, this is a sign that it's late. You are now late. You have to interfere before the blood pressure drops. This is extremely important point. So we have clinically tachycardia, as I mentioned, delayed capillary refill, and we talked about the blood pressure. So what are the disorders that can affect the fluids and the electrolytes? We'll try to separate them, but in real life, they don't occur separate. Meaning, usually they occur together. Like in congenital hypertrophic pyloric stenosis, you have hypokalemic, hypochloremic, metabolic alkalosis. You don't have disturbance of one of them, you have this combination. And usually they occur together. Most of the disturbances in the chloride, hypo or hyperkalemia, is associated with acid-base balance disturbances, as we are going to see. But we separate them just for the sake of teaching and education, but as a experience in neonatology, you should know that life is not that easy and they occur in combinations. So what happens to the fluid? What are the abnormalities? It's easy. It's either fluid overload or volume overload or dehydration. And the fluid overload is extremely serious in the preterm baby. And they think that if the baby gains more than 10% of body weight, this is serious, increasing the morbidity and mortality of this baby, like patent ductus, like BPD, and other problems. So what causes fluid accumulation? It's either the intake is increased or the losses are diminished. or there is a hemodynamic problem affecting the heart or the kidney. Like in heart failure, there is volume overload. In kidney failure, there is volume overload and presents clinically with edema. Okay. Also, if there is an inflammation or sepsis, the capillary permeability will be interfered with, and the fluid will go more and more into the interstitial fluid. Also, if there is low serum proteins or low serum albumin. Dehydration is the other way around, meaning the losses and from now onwards, you will hear these two words, intake and out. Intake, out. So the intake is less than the output. There is excess loss of fluids. And usually, as one of the compensatory mechanisms in any baby, when there is dehydration, the baby tries to maintain the intravascular volume by shifting fluids from the interstitial fluid to the intravascular fluid. So if the fluid is lost from the extracellular space at a rate exceeding the replacement, here we have dehydration. Or if there is diarrhea, if there is congenital chloriduria, if there is excessive vomiting. Okay? And these are the signs of dehydration based on the degree of fluid loss. It is mild, moderate, or severe based on how much body weight loss. If it's between 3% to 5%, this is mild. Up to 10%, it's moderate. More than 10% is up to 15%, it's very severe. More than 15%, the baby is in serious condition, is in shock, and maybe it's late. What are the manifestations? If the baby having mild dehydration, he will have normal mental status, normal heart rate, and the pulses are still bounding or normal strength or force. Capillary refill is okay, less than 3 seconds. Blood pressure is normal, respiration, there is not tachypnea. Eyes are normal, they are not sunken. Fontanelle is not sunken. Urine output is more or less maintained because of the compensatory mechanism. Once we go to the moderate, the baby starts to be irritable, listless, with increased heart rate. You see, heart rate is extremely important. It's more important than the blood pressure. The blood pressure is not affected unless late. And there is increased heart rate. The force of the pulse may be decreased or normal. Capillary refill starts to be prolonged, more than 3. And blood pressure is still normal because of compensatory mechanisms we talked about. And there is tachypnea. And there will be sunken eyes, decreased tears, and depressed fontanelle, decreased urine output. So once the dehydration is in the moderate stage, the urine output will become low. If you have severe dehydration, the baby will be more somnolent, more drowsy, with increased heart rate. Pulses start to be diminished in force, and they are called thready. Capillary refill is more prolonged. Blood pressure may be still normal, or when it's close to 10% starts to diminish, or it's more than 10% starts to diminish. Also, there is tachypnea and other signs, and the baby will become totally oliguric or anuric. These are important signs of dehydration. And dehydration based on the sodium level could be isonatremic, hyponatremic, or hypernatremic. If the sodium is between 130 and 150, this is isotonic dehydration. If it goes down less than 130, and some people use 135, it is hyponatremic. And if it is more than 150, it is hypernatremic. Can you give me an example of hyponatremic dehydration? And please vocal, I need to hear you, because the chat is full of comments. An example of hyponatremic dehydration. Hello? Congenital adrenal hyperplasia. Example of hypernatremic dehydration. This is easier. What can cause hypernatremic dehydration? Diabetes insipidus is an example. It is common in neonates with inadequate, this is important. If the baby is breastfed and is not getting adequate breast milk, he will become dehydrated and mostly hypernatremic, will be hypernatremic. Sodium will be high. This is another example. Polyuria is not a disease, it's a sign. A sign. When the urine output is more than 5 milliliter per kg per hour, and it is a sign of many disturbances like diabetes insipidus, like the diuretic phase of the AKI, acute kidney injury. And oliguria is the other, another symptom. It's when the urine output is less than 0.5 to 1 milliliter per kg per hour. And we see it in dehydration. And if there is acute renal failure, AKI, and this is the most common cause. And AKI could be pre-renal, renal, or post-renal. We discussed this in another lecture. Sodium disturbances. It could be hyponatremia or hypernatremia. Hyponatremia when the sodium is less than 135. And we used 135 instead of 130 because this will make you more cautious and will make your baby avoid more problems for hyponatremia. So use 135. What are the causes? Is in the early newborn period, and we talked about this in the diuresis phase, because it's, although it is water, there is diuresis of water and some natriuresis, but water loss is more than sodium, and there is insensible water loss, which is only water, especially in the preterm baby. So you could have hyponatremia, but this is not early. So don't give sodium early. If you give sodium early, this is another problem. You're interfering with the physiology, you're preventing physiology, you're going to overload, increasing morbidity and mortality. But you expect this by day of life like 3. And once the urine output is stabilized and checking the electrolytes, and you find them starting to drop around 135, you start giving sodium. Okay? or if there is excessive fluid intake, and this like in TPN, or in if there is SAD-H. And SAD-H can occur in the newborn babies, especially the preterm, secondary to IVH. Secondary to IVH. In the later in the newborn period, it is inadequate replacement of large renal losses, and this, like in diuretic therapy, congenital adrenal hyperplasia, or if the TPN has less sodium than required. Factitious hyponatremia occurs in cases of hyperglycemia. If the baby is having issues with the blood sugar, hyperglycemia, there is osmotic shift of fluid into the intravascular space because of increased osmolality secondary to the glucose level, will cause dilution of sodium. And it is factitious. The baby did not lose sodium and the intake was appropriate. And the sodium drops by 1.6 milliequivalent per liter for every 100 milligram increase in glucose level. So if you have baby with hyperglycemia and hyponatremia, no, you should know that it is not true hyponatremia. So what are the clinical manifestations of hyponatremia? Because of the shift of the fluids, there will be swelling. Somebody is talking to you. Are you asking for something? Hello? Hello?
لا يا دكتور ما فيش حاجة.
Okay. Because of the shift of the fluids from the extracellular to the intracellular compartment, there will be swelling of the cells, edema of the cells. Cellular edema is something serious, especially for the brain. So the manifestations of hyponatremia are mostly neurological, and because of the brain edema. And so the baby starts to become lethargic, irritable, starts to refuse feeding, might go into seizures if the level is very low. And with edema, there could be brainstem herniation and even respiratory arrest. And when we talk about treatment, we notice that hyponatremia should be treated slowly, and we will know why. If the baby is having chronic hyponatremia, and we see this in preterm babies, this also could interfere with the growth, as we mentioned, and cause seizures if the level is low. So chronic hyponatremia in the preterm baby can hinder the growth. Hypervolemic hyponatremia, when there is increased in SAD-H, inappropriate secretion of antidiuretic hormone. And as I mentioned, this could happen in babies with IVH. And this is the reason why we should treat hyponatremia slowly. Because if you are aggressive in treating hyponatremia, there will be what they call central pontine demyelination. Because you are turning the brain cells from edema to dehydration rapidly, which is not appropriate. And when we talk about treatment, we'll know why and how we can do that. If there is hypovolemic hyponatremia, this is true sodium deficit, because the baby is losing both sodium and water. And in this case, as we are going to see, treatment is bolus of normal saline. Hypernatremia, when the sodium level is more than 150. And it is because of loss of more water than sodium, or giving more sodium than required, However, the total serum body sodium may be normal, increased or decreased. It's only high in the in the intravascular compartment. Yeah, the limited urine concentration capacity of the newborn babies, although maybe this is in older infants that don't feel thirst and are not aggressive in feeding this. So they don't feel the sense of thirst as the older babies, and they are not taking much like formula or trying to take much fluid in breast milk. So causes of hypernatremia, either increased water loss, inadequate water intake, and excessive sodium intake, like in TPN. And excessive water loss, as we know that, like in insensible water loss through the skin or through the kidney or through the GI. Diabetes insipidus is one of the causes of loss of more fluids than sodium. And this causes hypernatremia. And it could be a result of HIE, by the way. If the baby is having polyuria in this condition, and they will have polyuria, will have hypernatremia because if you didn't replace water correctly. Also, we don't correct hypernatremia rapidly, as we are going to discuss in treatment, because if you do that, you might induce cerebral edema and seizures. So there is a way to replace, to treat hypernatremia, and don't drop it more than 0.5 milliequivalent per liter per hour, as we are going to see. Excess sodium intake, as in TPN. So in hypernatremia, we have, as we mentioned, decreased blood pressure, decreased urine output. Typical signs of dehydration will be, yes, the hypertonic dehydration, because it causes cellular dehydration. It gives you the classical manifestations of dehydration, like dry tongue, dry mucous membranes, in addition to the tachycardia and decreased capillary refill, sunken eye, sunken anterior fontanelle, and other problems. So this table summarizes the causes of hypernatremia: excessive water loss relative to sodium, or if there is renal loss of fluids more than sodium, like in diabetes insipidus, or in diuresis, or in diuretic phase of renal failure. If there is loss of more fluid than sodium through the GI by diarrhea, or inadequate intake if you don't give adequate fluids, or the TPN is not appropriately prepared. Okay? Or if the sodium is increased, so either the water take is lost or not given adequately, or sodium is increased because of excess sodium, like giving many injections of sodium bicarb in a baby with acidosis, you might turn this baby into hypernatremia. Okay? Potassium disorders is either low hypokalemia when it's less than 3 milliequivalent per liter. And the most common cause of hypokalemia, we see this in chronic diuresis in the preterm babies because they lose sodium and potassium. In renal tubular defects, and an example of that is the Bartter syndrome. Bartter syndrome, where there is polyuria, hypokalemia, hypochloremia, metabolic alkalosis, and even hyponatremia. Okay, how can hypokalemia present? Most of the time it is asymptomatic, but it causes, because it is part of the intracellular, it's an intracellular component of all the organs, including the muscles. So it can cause weakness, paresis or paralysis ileus, urine retention, problems with the heart. And the EKG findings are ST segment depression or low voltage T wave and U waves. And these are collection of the causes of hypokalemia, including renal losses, as we said, or if you give a lot of mineralocorticoids, like giving steroids, if there is a kidney problem, as we see in the Bartter syndrome, in diarrhea, in diuretics or diuresis, there's many causes of hypokalemia. Hyperkalemia when the potassium level is more than 6. And we said that the newborn baby, the preterm babies, are liable to have hyperkalemia in the first 24 to 72 hours. So this is extremely important. So this is one of the major causes of hyperkalemia. Other causes include renal problems. And as we said, hyperkalemia in the preterm because of shifts from intracellular to extracellular potassium after birth. This was the answer for one of the MCQ questions. So in renal failure, hyperkalemia is a problem. In preterm babies, it is an issue. Factitious hyperkalemia when you are doing sampling, when you do capillary sample and you squeeze the heel of the baby, you are causing hemolysis and will give you hyperkalemia. What are the manifestations of hyperkalemia? The EKG findings are important. There is peak T wave, flattened P wave, increased PR interval, widening of the QRS complex, and these changes depend on the level of the potassium. And hyperkalemia is more serious than hypokalemia. Chloride usually follows sodium, and it's also affected by acid-base balance. So you could have hypochloremia or hyperchloremia. The normal chloride level is between 96 milliequivalent to 106. If it is less than 95, it's hypochloremia. If it's more than 110, it is hyperchloremia. So this is hypochloremia, and usually the cause is either loss through the GI or loss through the kidney. GI, like in chronic hypertrophic pyloric stenosis, or kidney, like Bartter syndrome, vomiting, diarrhea, and acidosis can cause hypochloremia. Hyperchloremia, when the level of the chloride is more than 110, and usually we see this in dehydration, in congestive heart failure, and in BPD, in chronic lung disease. One of the disturbances also is of the fluid and electrolyte is the acidosis. And we know that acidosis is either respiratory, which is not part of our topic, or metabolic acidosis. And this shows you how you compensate for metabolic acidosis and for metabolic alkalosis, and the other way around. So metabolic acidosis, when the pH is less than 7.2, it has many causes. One of the important is the inborn errors of metabolism, like organic acidemia, renal problems, like renal tubular acidosis, in proximal renal tubular acidosis, or in distal renal tubular acidosis. Also diarrhea and loss of acid, of alkali, okay? And you have to calculate the anion gap. You should know how to calculate it. It should be between 8 and 16, and normal anion gap acidosis is important to deal with. Also lactic acid acidosis, hypoxemia, important causes of acidosis. When the pH is less than 7.2, cardiac contraction will be affected. Pulmonary vasoconstriction occurs, increasing PPHN. Pulmonary hypertension may develop, and the baby will be having lethargy and coma. Metabolic alkalosis is the other way around. And when the pH is more than 7.5, and we see this in cases like congenital hypertrophic pyloric stenosis, in kidney problems, Bartter syndrome, or loss of acid, or giving excess alkali. There is a correlation between the movement of potassium and hydrogen ion. And hydrogen ions move from the extracellular fluid into the cells in the hypokalemia, which is not a common cause of metabolic acidosis. Which it could be, but it's not a common cause. So if there is hypokalemia, you could have metabolic acidosis. And metabolic acidosis affects potassium also. It causes hyperkalemia. If you administer excess alkali, you will introduce metabolic alkalosis. And the alkali we administer sometimes is sodium and potassium acetate. And sometimes we use this in the treatment of metabolic acidosis in the preterm babies. You switch the sodium chloride in the TPN to sodium acetate, and the same for the chloride. So metabolic alkalosis could be part of hypovolemia, as in Bartter syndrome. I mentioned this before. Or it could be part of hypervolemia. And important alkalosis is contraction alkalosis. And we see this in preterm babies who are having BPD, and they are on long-term diuretic therapy. Diuresis at some point will cause contraction alkalosis. And it's one of the complications or side effects of the loop diuretics. Also, we can see this in congenital chloriduria, which is loss of chloride and through the GI, and this will be reflected in contraction alkalosis. Okay. Monitoring, as we discussed before, we have to go clinical. We have to monitor vital signs, clinical exam. An important issue is the body weight. You have to monitor the body weight. You have to monitor the intake. You have to monitor the output, whether through the urine, stools, or other issues like gastric aspirate or any other fluids and electrolytes loss. And you should monitor the electrolytes, especially the sodium, serially. The body weight is a good indicator of dehydration, but this is not absolute, because as we said, in the dehydration, the body weight might give you a false impression about, especially in the preterm babies, especially when they are already losing weight physiologically. So be careful about that. And we talked about the physical exam and signs of dehydration, of fluid overload, hypo and hypernatremia, hypo and hyperkalemia, hypo and hyperchloremia, metabolic acidosis, metabolic alkalosis. We talked about that, yes. Yeah, a preterm baby, extremely preterm babies, and babies at other sick babies in the NICU should be weighed at least once or twice per day. This is extremely important, because this will give you an indication if there is a disturbance in the fluids, if there is dehydration or weight gain, or fluid overload. And when you do more than once a day, you look also at the trend, because one time measuring of the weight might not be adequate. You look at the trend. Is the trend of the weight is going up, gaining weight inappropriately, or down, losing weight inappropriately? And taking into consideration the physiological loss of weight, as we mentioned, and daily weight loss is an important guide in planning for maintenance fluid therapy, and should be 1 to 2% of body weight in term infants and 2 to 3% of body weight in preterm infants. I don't know what is this about. Never mind. And you should record. You should have a record of the intake, whether oral or enteral or through lines. This all should be calculated. And then the output, urine, stools, gastric aspirate, CSF, leak, whatever. You should document this very carefully. And also the urine output, as we said, is a very good indicator of the fluid and electrolyte status. And then you not only you do just urine output, you do labs. What are the important labs you should do? You should do serum electrolytes, serum osmolality, BUN and creatinine. You should do urinalysis, the normal, urine sodium, fraction excretion of sodium, urine osmolality, and you should check also blood sugar and blood, the proteins or the albumin. These are the important laboratory labs that you should do, and you should use them to monitor the baby and follow up the baby and see the response to treatment. Total fluids given, total electrolytes, intake, output, losses. Is the baby healthy or sick? Is the baby term or preterm? This is going to help you a lot in managing sodium and fluoride and electrolyte disturbance. I'm going to stop at this point. And next time, inshallah, we'll continue. We don't have much left, and we have the answer for the MCQs And we have 4 clinical cases with fluid and electrolyte disturbances. Now, questions. Mute all, مفيش صوت. Management for this electrolyte disturbance. What is this electrolyte disturbance? We will talk about the management next time, as you are going to see. This is going to be next time. So we will discuss the management next time. What else? البلة منه ميتابوليك. في اجتماع الضيف البروف، يا مرحبا انا وانت، بس انا مش فاهم حاجه. انا معاكم
ده كان شات في الاول يا دكتور، كان شات في بدايه المحاضره.
نعم،
ده كان كلام في بدايه المحاضره.
طيب any questions يا جماعه please؟ any
محدش
comment؟
سأل حاجه حتى الان يعني.
So
لو
either
في اي
you
حد حابب يسال بالمايك ممكن يرفع ايده ونفتح له المايك.
yes you can vocalize your question. You can talk. No questions, which is a bad sign. Okay, please read when this presentation is on the YouTube. Please revise it and revise the initial part.
يا دكتور احنا موجود على اليوتيوب من دلوقتي لايف.
Okay, great. And
في سؤال يا دكتور إيهاب.
yes.
In calculation of TBN in preterm and trial feed
Calculation of
how؟ مش فاهم ايه المقصود من السؤال.
how it
ممكن توضح السؤال يا اللي سائل؟
how what is how؟ اتكلمي حضرتك اتكلمي. سؤال: why no need for sodium in the first day of life? I'm sad to hear this question, to be honest with you. Why no need for sodium in the first day of life? This means that you were not focusing, you were not concentrating. We talked about this many times in this presentation. I'm sorry. Could please repeat diabetes insipidus? In diabetes insipidus, there is polyuria because of excessive secretion of the because of the lack of antidiuretic hormone. There is polyuria, and it is mostly water because the and there is no much loss of sodium. So there will be hypovolemia, hypernatremia. Sorry. There will be, yes, hypernatremia, and the urine excretion of sodium will be low. Urine osmolality will be low. I think this is enough for the diabetes insipidus. What other question? Why no sodium? No, I will not answer this question. You go back to the lecture. What else? No questions. If case of full term has generalized edema with high creatinine, but no electrolyte disturbances, how calculate fluid intake? So you have to give more information. These information are not enough. You have to let us know what is the urine output, what are the vital signs, and what are give me the electrolyte levels. What is the BUN and creatinine? Okay. And then based on that, we'll know what is the problem for this edema. And this baby could have congestive heart failure. He will have edema. You said high creatinine? So high creatinine, I didn't see this. It might denote that the kidney is not, might denote AKI, acute kidney injury. So this baby, was this baby having HIE? What was the history, maternal fetal history? I see this a lot on the on our website. When you ask a question, a clinical question, you have to present the case properly. And presentation of a case is an art. You have to tell me this baby is how many weeks? Gestational age. How was the Apgar score? How was the family history, maternal history, if there is something significant? And immediate prenatal history, immediate neonatal history. How was the baby born? How did the baby require resuscitation at birth? How was the Apgars, as we said? And physical exam immediately and later on in the NICU. And why the baby was admitted to the NICU? And what is the main clinical problem? And what did you find on clinical exam after you had this problem? Did you have a heart murmur, evidence of cardiomegaly, diminished pulses, high or low blood pressure, decreased capillary refill? And where is the edema? What is how is the jugular venous pulsation? You have to give me a full detailed clinical exam. And then what labs did you do? How was the saturation? This baby required oxygen or not? Did you do an X-ray? Did you do a babygram? And then we can discuss the case. Because I am not a magician. You don't think when you say a term baby with edema and high creatinine, no electrolyte disturbance. I cannot calculate fluids because I don't know what I'm dealing with. Because we still have a problem of this could be cardiac, this could be renal, this could be inadequate breastfeed. I don't know what was the baby fed. What are the input and output, the intake and output. So please, please, please don't send these mysterious questions to the website and to any person, because there is a difference between a clinician, an intensivist, and a magician. Don't take this personal, because this is what every and each one of you does, which I don't like. So please revise this case carefully and send it back to me in details, as I told you. And then we can discuss the case and know what is the problem, and then what are the fluid requirements for this baby. Is this a good answer? I don't know. Okay, 5 more messages. What difference between diabetes and SIAD-H? They are opposites. They are totally different. Diabetes insipidus is inadequate it is polyuria, hyponatremia, low sodium, polyuria, hypernatremia, low sodium in the urine, low urine osmolality. SIAD-H is inappropriate secretion of anti-diuretic hormone. Diabetes insipidus is absence or decreased antidiuretic hormone. Antidiuretic hormone prevents water loss. So when it is deficient or low, there will be water loss through the kidney. So this is diabetes insipidus. In SIAD-H, it is the opposite. this antidiuretic hormone is excessively secreted for no reason. It is not indicated. There is no hypovolemia. There is no other cause to stimulate SADH. So excess antidiuretic hormone will lower the urine output. So different from diabetes insipidus. It causes oliguria. Diabetes insipidus causes polyuria. SADH will retain fluids, so causes hyponatremia. Diabetes insipidus causes hypernatremia. Okay? SADH will increase sodium concentration in urine, unlike diabetes insipidus, where the sodium in urine is low. Urine osmolality is low in diabetes insipidus and high in SADH. Okay? Thank you. Thank you. Does HDSPDA, I don't know what is this.
hemodynamically significant BDA.
يا راجل مين اللي بيخترع الاختصارات دي؟ مين يعني is this accepted abbreviation يا دكتور أحمد؟ Hemodynamically significant beta ductus arteriosus bear in weight in our initial TPN calculation. يعني ايه bear in weight؟ حضرتك
in case
قصدك
of
ايه؟
إن في hemodynamically significant BDA, do we stick to the original TPN volumes according to the table يعني ولا بنعمل restriction?
Yes, 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 yes. You do go down on the total fluid, but you go up on the calories. But this question is not related to our article, but yes, you go down on the total fluids and you compensate by going up on the calories, either by going up on the protein or whatever. Okay? What else? Dr. Marwa Mubarak. Amount of sodium per hour target in the correction of hyponatremia. We didn't talk about correction of hyponatremia. This will be next time. This is going to be next time. Is adding phototherapy in case of neonatal jaundice makes us add additional volume of what?
هل
To the
الفوتوثيرابي يا
starting,
دكتور
yes. So phototherapy is an indication to go up on the IV fluids, if the baby is on IV fluids. And if the baby is taking PO, if the amount of PO is adequate, okay. If not, you can give IV fluids extra. Yes, it will increase the requirements of fluids. The answer is yes.
في
And
سؤال تاني
then
يا دكتور في Q&A.
now,
kindly regarding the preterm baby, how many days can he be kept on IV fluid only without TPN? Thank you.
only without TPN, you can start TPN from the first day. But these questions are not in the, never mind. You can start TPN as early as the first day. And one of the MCQs I gave to you, they started TPN in the first day. But this is another story. When we talk about TPN, when we talk about feeding, which we did before, we can discuss this in brief. A stable, healthy term infant on phototherapy for ABO incompatibility is required for IV to compensate fluid loss, or the already good oral feeding is enough. والله حضرتك السؤال ده انت جاوبته. If oral feeding is enough, it's okay. You have to calculate intake and output, and you have to check the weight of the baby, the urine output, the serum sodium and other electrolytes, and the clinical condition of the baby, tachycardia, capillary refill, whatever. And based on that, you will decide how much fluid does this baby take. If he's taking enough, no problem, whether PO or IV. If not, you can give IV. You can give the rest IV. Thanks. خلاص يبقى إن شاء الله next time هتكونوا كلكم راجعتوا revised, reviewed the part 1, part 2, and be careful sometimes because I'm 73 years old. Sometimes I forget something or I mean something and say something else. So be cautious about that and correct me if you think I did something wrong. I will be happy for that because I don't need to give you any false information because this is going to affect your practice and affect your babies in a negative way. So please review other parts because next time we'll review, we'll finish. And it's the most important part because it is the management. And actually, this is the goal of this lecture, of this series of lectures, is to know how to manage fluids and electrolytes in the newborn baby, whether term or preterm, taking into consideration the daily requirements, and we mentioned that, the insensible water loss, the diuresis, and the transitional changes, and how preterm differ from term, and how the postnatal age affects the fluid requirements and electrolytes. And lastly, the environmental factors and the pathological condition. If this baby is having RDS, neck, BPD, taking diuretics, having heart failure, you have to manage that based on these changes. And then after discussing the management, we'll go again through the MCQs, and every and each one of you should know the answer for all the 10 questions. And then I will show you some. We have 4 clinical cases, depending on the time, of fluid and electrolyte disturbances. Thank you very much. Assalamu alaikum. I wish this was helpful. And thank you very much. Assalamu alaikum. See you
شكرا
next.
جزيلا يا دكتور.
شكرا لحضرتك.
مع
شكرا.
السلامة. السلام عليكم.
شكرا. مع السلامة. وعليكم السلام ورحمة الله وبركاته.